So this is Gina. Looks like we're dating, but yeah. So we're gonna start with the carpal tunnel. Okay, this is the exam for the carpal tunnel. So the way I like to do Tinel's, can you guys see this? Okay, yeah, that's better. So when I tap for Tinel's, I actually use 2 fingers and I tap pretty hard like this. Okay, and then they usually tend to have zinging into the fingers. It's not this, the tap is not this, it actually has to be pretty vigorous, okay? And so that would be the Tinel's. Another test that I do is for the APB atrophy. So APB is a structure that would be over here, okay, over here, APB. And the way I test them is I have them bring their hands like this and have them make a 7 like that, okay? So it's not thumb extension, it's palmar abduction, okay? And when I do that, I like to, let me see, can you guys see that? I like to feel APB here, and then I have them resist. Can you put it down? Resist, and I push, like that. And so I'm testing the quality of muscle and also the strength. That's for that's the motor test for carpal tunnel. Valens test is this, valens test, reverse valens, okay? And then the one I really like is called the Durkin test. So I compress right there between the thenar and hypothenar compartments, and I push here with 2 fingers, and I flex like that, okay? And that's I think this is the most sensitive test for carpal tunnel. Another test for cubital tunnel syndrome is when you have compression of the nerve here. The ulnar nerve innervates the sensory distribution. It will innervate the small finger and half of the ring finger, so the small finger and half of the ring finger. So what I start with is Tinel's at the elbow. So if you feel your medial epicondyle, the bump, if you feel the medial epicondyle, the bump, right behind it, that's where the ulnar nerve lives. So that's the funny bone. So you tap there and see if they have any zinging, okay? Another test for compression is the reason people get nighttime symptoms is because we tend to flex. So I do elbow hyperflexion test. So I hold them like this and ask them if it goes numb. And a lot of times their fingers will go numb after, I wait for about a minute, but then usually within 15 seconds it tends to go numb, okay? In terms of motor testing for cubital tunnel syndrome, the ulnar nerve innervates the profundis tendons to the small finger and ring finger, which is the tendons that bend at the DIP joint, so this joint here. So when I test for motor, I will have them flex the pinky, and I test here, okay? Flex the pinky, and I'll test here. Another thing that the ulnar nerve does, it innervates most of the hand muscles. There's a muscle called first dorsal interossei over here, and so I have them abduct, so I have them bring it out like this, touch my finger, and I push. And this muscle here, the first dorsal interossei, is ulnar nerve. Another test for ulnar nerve is the adductor here. The adductor is a ulnar innervated muscle. So what I have them do is have them do like a key pinch, and hold it, and then I'm gonna pull, and then I have them resist. Don't let me pull, okay? What happens with people who have ulnar nerve dysfunction and they can't hold the paper, what they do is they actually flex here, because it's flexor pulsus longus is a median innervated muscle, and so what they do is they flex, and they'll hold it like this. That's a positive test. The other test that I like to do is have them open their hand, and then open it, close it. There's a sign called Wardenberg's where their small finger, open it, and close your hands, and this one will lag or they won't be able to close it. It's called Wardenberg's test. It's because the intrinsic muscles that open and close your fingers, they're weak, and then there's an extensor tendon that has an ulnar vector, okay? And so it won't allow you to close your finger. That's the Wardenberg's test. Now let's go, I'm gonna go to trigger finger. Like I said, a lot of patients will complain of pain in the PIP joint here, but the pathology, it's here. So can you zoom into the crease? You see that? That's the distal palmar crease. And then you have the finger creases here. So the A1 pulley is somewhere in this region here. And so what I do is I push right there. If they have pain, for me, that's trigger finger, and that's where I inject my corticosteroid. Okay? The CMC test for the grind test. So if you take your finger and you just roll it down the back of the metacarpal cortex, it will dip in. That's where the CMC joint is. So the way I do the CMC grind test is I grab the head of the metacarpal and I grind it like this. CMC test. I also like to put my finger at the joint, and I like to grind down on the joint. And a lot of times they have inflammation, they have pain there. That's CMC arthritis. So I push here and I also grind. Okay. Let's see. So that's CMC. Fromans test. So this is the Appleby tendons, and right here is where you have the sheath. And a lot of times they'll have pain around this area, around the area. One gentleman asked about intersection syndrome. Intersection syndrome is about 3 centimeters proximal, somewhere around this area. So if you look at someone's wrist, let me see, maybe mine here. Can you see it? There's a bump here. Okay? So this is where intersection syndrome occurs. So the wrist extensors and your Appleby muscles, they cross over. That's where intersection syndrome occurs. Fromans is over here. Okay? Intersection syndrome, Fromans. And the way you do the Finkelstein's test is you put your thumb in your hand and then just ulnarly deviate. Ulnarly deviate. Okay? Another useful landmark, have you guys heard of the snuff box? The snuff box. So when you push down on the snuff box, that's where the scaphoid waist is. And if you push hard enough, most people, even normal people with no scaphoid fractures, have pain there. So if you're suspecting a scaphoid fracture, I usually start with the contralateral, just get their baseline pain, and then I push right there to look for scaphoid fractures. If you turn it over at the level of the wrist crease, there's a bump. That's actually the scaphoid tubercle, so the head of the scaphoid. It's the scaphoid tubercle. So I push here and I push here, looking for scaphoid fractures. Okay. Anyone have any questions so far about the hand exam? Yes. TFCC, great question. So hard to answer because it's called the black box of hand surgery because there's a lot of things that can happen. Okay. So for TFCC test, let me show. So the test I like to do is called the ulnophobia test. So if you put your hand up your ulna, there's going to be a spot where it kind of dips in, and that's where the TFCC attaches. So I push there. If that pain there, for me, it tells me there's some TFCC pathology. I also take the wrist and ulnarly deviate it at the same time, like this. And that pain, that tends to be a TFCC injury. The reason I didn't talk about the TFCC is because, like I said, it's the ulnar. I could spend an hour talking about the ulnar-sided wrist pain. But when you have TFCC injuries, you could also have DREJ instability, as Dr. Zhang mentioned. So can you see? Let me see this wrist. So the DREJ is over here, and what I do is to test for DREJ instability, you have to actually stabilize the radiocarpal joint and then shuck the ulna. But you have to do this in pronation, neutral, and supination, okay? So to assess that's sort of a little more complicated. It's even also hard for us to assess for TFCC injuries, okay? Yes?
Show the exact spot you would inject for the CMC.
Okay, let me see. So what I like to do is when I inject for the CMC, I actually grab the thumb and I pull on it because it opens the space. So for you, I'm going to use can you see this? Okay. So I will march down the metacarpal, and it'll dip here, right there, and that's where I inject. So if you take your own thumb and just march down your metacarpal, there's going to be a spot where it dips in. That's where the CMC joint is.
What's your line of drive on that?
My what?
Are you going direct and perpendicular or slightly?
Yeah, so the CMC joint, I don't go directly down. I actually go, let me see. You have a pen? Anyone have a pen I could borrow? Thank you. So I go directly dorsal when I inject. I don't go from the side. And so if this is a spot, I don't go straight down. You won't hit it. You actually have to hug the metacarpal. So I go at this 15-degree angle. Okay? A lot of times it's really hard to hit if it's really arthritic because there's no space. Then I have to use a fluoro scan to try to get in there. Any other questions?
Can you repeat the ulnar nerve test?
The ulnar nerve test? Yeah, of course. So the ulnar nerve innervates the profundis tendons to the small finger and ring finger, which bends at the DIP joint. So what I do is I grab here and I have them bend your small finger, and this is what I test for strength. Okay? The DIP joint, the distal joint. Okay? It also innervates the interossei, which the inner ossei, the function of the inner ossei is to open and close your fingers like this, abduct and adduct. And the one that's easy to palpate is the first dorsal interossei. So if you, can you touch my finger? Can you guys see that? Right there? Or maybe, can you guys see that here? Yeah? So that's the first dorsal interossei. So I like to palpate that. Can you touch my finger? And then I push. And that's the first dorsal interossei. Deeper, there's something called the adductor, the thumb adductor. So it helps us pinch the adductor. And this test is called the Fromans Test, F-R-O-M-E-N-T, Fromans Test. So when someone has a good key pinch, they're able to use the adductor to hold this piece of paper. So I'm going to pull, right? She's holding. If your adductor is not working, to compensate, you actually flex your thumb because using your flexor pulses longest. So a positive Fromans test is when you bend your thumb. Okay? The other test that I mentioned is the Wartenberg's test, W-A-R-T-E-N-B-U-R-G, is when you open your finger and I ask you to close, and then the small finger just won't come all the way. That's a positive Wartenberg's test. Okay? Any other questions? Yes?
You mentioned water-soluble steroid. Is Kenalog water-soluble steroid?
Yeah, that's a great question. So Kenalog is water insoluble. And the reason why I use that for like trigger finger is because once it precipitates, theoretically it has a longer lasting effect. It's a solid. The water-soluble ones are like dexamethasone, celestone, betamethasone. So you have to sort of figure out which ones you have available and find out if it's water-soluble or not. And like I said, I usually do water insoluble for like the trigger fingers and also even the carpal tunnel. But something that's superficial, I tend to use water-soluble, like diclofenac. Okay? Yes? The Durkin Test. So, can you guys see the thenar compartment here? Right there, the bump, and then this is the hypothenar compartment, and there's a valley in the middle. So the carpal tunnel lives somewhere in the valley. So what I do is I will compress here, in between, and then the way it was originally described by Dr. Durkin is you actually just compress here and don't bend the wrist for a minute. But then the way I kind of modified it for myself, I like to bend it a little bit, maybe like 30 degrees or so, and I compress. That's a Durkin's test. Okay? Yeah, so when like a classic carpal tunnel patient comes and they say it's my thumb, index, long, and ring finger, I get really excited if it's classic because a lot of patients are not classic. A lot of patients will say it's just my thumb, or they'll say it's my thumb and small finger, and you're scratching your head. In those cases, I tend to get an EMG. But then it could actually be any finger. It could be like numbness in the ring, like the thumb, but these two are okay. So it doesn't have to follow a classic pattern. But that's a good question because not everyone comes with that classic picture. Yes?
Locating the palmaris longus.
Yes, good question. Let's see if you have one. So I'll show you mine. So I take the thumb, and I take the small finger, and I flex the wrist. Can you guys see that? Can you show? Do you have one? Yep. Who doesn't have one? You don't have one? Okay. We should try a carpal tunnel injection, and you see. So if you don't have a palmaris longus and you want to inject, what I use as a landmark is you can use your ring finger, and you know that the median nerve is a radial structure in the carpal tunnel. So I tend to be on the border of the hypothenar eminence is where I inject. But if you don't have a palmaris longus, it's actually kind of tricky to inject the carpal tunnel. Okay. Any other questions? Right. Thank you.